Assalamu alaikum. With the definition of ectopic pregnancy. Ectopic pregnancy, as we see in this picture, on the fallopian tube, this is a laparoscopic picture. What about the incidence and the etiology of ectopic pregnancy? Fallopian tube damage is the first cause of ectopic pregnancy due to pelvic infection, especially by sexually transmitted disease as chlamydia and gonorrhea, previous ectopic pregnancy, and previous tubal pregnancy. So the anatomy of the tube is disturbed. The other main cause is physiological functional alteration of the fallopian tube, such as delayed transport or reversed peristalsis of the fallopian tube that may be associated with smoking or increased maternal age more than 35 years. This figure some clinical presentation of ectopic pregnancy. The diagnosis of ruptured ectopic pregnancy is usually clearly as they present with signs of acute abdomen and hypovolemic shock with a positive pregnancy test. So, in any woman, clinical evaluation is of utmost importance. Thorough clinical evaluation is very important in evaluating a case of ectopic pregnancy. What about the investigations? The most important investigations are one imaging and one laboratory. The imaging is transvaginal ultrasound. The laboratory is beta HCG estimation. We start with the transvaginal ultrasound. By transvaginal ultrasound, we can identify an intrauterine pregnancy with intrauterine gestational sac plus yolk sac plus or minus fetal pool. This excludes the possibility of ectopic pregnancy in most patients, except in those with rare condition of heterotropic pregnancy. A transvaginal ultrasound showing an empty uterus with an adnexal mass has a sensitivity of 90% and specificity of 95% of diagnosis of ectopic pregnancy. However, unfortunately, this is not the condition in all patients. Usually, we fail to identify an adnexal mass, but just empty uterine cavity with a positive pregnancy test is a suspicion of ectopic pregnancy. These two photos, this photo, the second important investigation is the lab investigation, which is serum HCG evaluation or estimation. The serum HCG level almost doubles every 48 hours in normally implanted pregnancy. Other important investigation: pregnancy of unknown location. In about 40% of women with ectopic pregnancy, the diagnosis is not made on first attendance and labeled as having POL, pregnancy of unknown location. A pregnancy of unknown location is a working diagnosis defined as an empty uterus with no evidence of an adnexal mass on transvaginal ultrasound in patient with positive pregnancy test. The mainstay of an investigation of pregnancy of a null location is consecutive measurement of history of human chroniogonadotropin, and endometrial biopsy can occasionally or may occasionally be helpful when human chroniogonadotropin levels are static, not increasing, not decreasing. All PUL must be investigated to determine the location of pregnancy. This is an algorithm helping the diagnosis and management of cases of PUL. The main determining factor here, if the patient is hemodynamically unstable or hemodynamically stable. If she is hemodynamically unstable, immediate laparoscopy or laparotomy is performed. If she is stable, we refer to the pain. If she had lower abdominal pain with positive pregnancy test and non-identifiable location for pregnancy, we start serum beta-HCG evaluation while we are considering laparoscopic management. And if there is no pain, we start investigation at ease. We estimate beta-HCG level and repeat it after 48 hours. According to the result of the 48 hours beta-HCG, the management goes. If the beta-HCG after 48 hours increased by 60% of the baseline level or more, this is mostly an intra-abdominal pregnancy, and after 7 days, the sac will be apparent by ultrasound. If the increase is less than 60% of the baseline level, it is mostly ectopic pregnancy. If the beta-HCG after 48 hours decreases, what amount to decrease? If decrease is less than 15%, this is a failing PUL, a weak pregnancy of unknown location, and we repeat beta-HCG after 1 week. If the decrease by more than 15%, it is a failing PUL. Urine pregnancy test after 2 weeks. We come to the management of ectopic pregnancy. Ectopic pregnancy can be managed using an expectant medical or surgical approach, dependent on clinical presentation and patient choice. We start with expectant management. The rationale behind the expectant management is the assumption that a significant proportion of ectopic pregnancy will resolve by themselves without treatment. This option is suitable for patients who are hemodynamically stable and asymptomatic and still so. Asymptomatic and hemodynamically stable. The patient requires serial beta-HCG measurement until the levels are undetectable. Medical management of ectopic pregnancy means the use of intramuscular methotrexate therapy. It is indicated in certain circumstances when follow-up is accurate. The patient with minimal symptoms, adnexal mass is less than 4 centimeters by transvaginal ultrasound. The current serum beta-HCG level is less than 3,000 international units per liter at the start of medical treatment. Methotrexate is a folic acid antagonist that inhibits DNA synthesis, particularly affecting trophoblast. The dose is calculated based on the patient surface area, and the dose is 50 milligrams per square meter surface area. After methotrexate treatment, serum beta-HG is usually routinely measured on days 4, 7, and 11 after the start of methotrexate therapy, then weekly thereafter until undetectable levels are found. Levels need to fall with proper response to treatment by 15% between day 4 and day 7 and continue to fall until treatment is ended. Medical treatment should be only offered if facilities are present for regular follow-up visits. What are the contraindications for methotrexate therapy? Women with chronic liver disease, women with chronic renal disease, women with hematological disorders, women with active infection, women with immune deficiency, women breastfeeding their babies. The side effects of methotrexate therapy include stomatitis, conjunctivitis, gastrointestinal upset, photosensitive skin reactions, non-specific abdominal pain is experienced by about 2/3 of the treated patients. It is important to advise women to avoid sexual intercourse during treatment and to avoid conceiving for 3 months after methotrexate therapy because of the high risk of teratogenicity. It is also important to advise them to avoid alcohol and prolonged exposure to sunlight during treatment. The standard surgical management of ectopic pregnancy should be delivered through laparoscopy. The use of laparotomy is reserved to severely compromised patients or there is no facility for laparoscopy. The operation of choice is removal of the tube and its content of ectopic pregnancy, a condition termed salpingectomy. And this is the best method. Some cases, some physicians prefer salpingotomy, opening an incision against the ectopic pregnancy, evacuating the fallopian tube with hemostasis, aiming to preserve the tube. Another method is salpingostomy, opening the tube. Both salpingectomy and salpingostomy are followed by high rate of recurrence of ectopic pregnancy in the same tube. This laparoscopic picture shows a left ectopic pregnancy surrounded by the red arrows, distending the tube with bluish discoloration of the distended tube. This photograph, the surgeon showing in his right hand a left fallopian tube removed and its gestational sac content with a transparent amniotic sac and inside the fetus. The blackish area is a blood clot. And in your hand, right hand, picture showing an embryo 7 weeks extracted after opening the tube by laparoscopy. Salpingostomy is recommended if contralateral tube is absent or visibly damaged, and the operation of salpingostomy is associated with higher rate of subsequent ectopic pregnancy in the same tube. I myself prefer salpingectomy, even if it is a single functioning tube, and the patient has a higher incidence of getting pregnancy through ICSI or IVF. Pregnancy rates subsequently remains high if the contralateral tube is normal. What about the Rh negative patient with ectopic pregnancy? Rhesus isoimmunization can occur after only early pregnancy problems, and there are some circumstances where women who are Rh negative and their husbands are Rh positive require anti-D prophylaxis. All Rh negative women who have a surgical procedure to manage ectopic pregnancy or miscarriage should be offered an anti-D immunoglobulin at the dose of 50 micrograms or 20 to 150 international units as soon as possible within the first 72 hours of surgery. Clear test is not recommended to quantify the fetal-maternal transfusion in the first trimester. Anti-D is not required in threatened, incomplete, or complete spontaneous natural miscarriage that not include a surgical interference. Anti-D may not be required after medical management of ectopic pregnancy with methotrexate. However, the guidelines are variable from country to other, from society to other, so prophylaxis is given oftenly. We finished the lecture now. I wish I covered all the aspects about the ectopic pregnancy, and we come to the self-assessment. We have two cases. Case number one is a female, 25 years old, present with a vaginal bleeding and positive pregnancy test. Her TVS shows an non-viable intrauterine pregnancy. What would be reasonable to offer her as a treatment? Do you offer her a laparoscopy, serum, beta-HCG measurement, misoprostol, methotrexate, or progesterone? Let us discuss all the choices. Laparoscopy is not suitable as the pregnancy is intrauterine. The second case is Mrs. X, who is 32 years old, who presents after 6 weeks of amenorrhea with abdominal pain and dizziness. Her observation on admission was blood pressure 90 over 50 millimeter mercury, pulse 120 beat per minute, temperature is normal. She has positive urine pregnancy test. What is your differential diagnosis? The best is differential diagnosis is ectopic pregnancy. What are the key points in her history examination and investigation? The key points in favoring the ectopic pregnancy diagnosis are reproductive age, 32 years, presenting with symptoms which are pain and dizziness. She also has signs of hypovolemic shock. She has a positive pregnancy test. History, the age of reproductive age. Symptoms, pain and dizziness, signs, hypovolemic shock, and investigation, positive pregnancy test. The management should be aimed to resuscitation of the patient first and laparoscopic management of ectopic pregnancy. Thank you very much. I wish you all the best of luck.